It's a great privilege for me, and it's a great honor for me to share the dais with Dr. Debashish Konar. So today I'm going to talk about one of the most crippling, most disabling form of mental illness, and that is the OCD. And I'm going to talk on the clinician's dilemma. Organizers, please confirm whether my slides are visible.
Yes, sir, visible. Make it full screen.
Yeah. OCD is one of the most disabling mental illness, and World Health Organization have listed it as one of the top 10 illness causing disability. So the concept of OCD have changed over time. If we basically see the basic pathophysiology of OCD, then we can see that if we see the neurobiology of the OCD, then the lateral and medial orbitofrontal cortices, dorsolateral and cingulate cortex, amygdalocortical circuitry, and the corticostrial circuitry are mostly involved, and it takes us to the direction of anxiety spectrum of illness. But if we see the recent conceptualization in the DSM-5, we can see that it is going out of the umbrella of the anxiety spectrum of illness, and it is going towards more towards like hoarding disorder, body dysmorphophobia, trichotillomania, excoriation, towards this type of illness. And so its pathogenesis is heterogeneous, and it is characterized by its high rates of refractoriness. So despite OCD being a common mental illness, most persons seek treatment after several years of suffering. And those who suffer from OCD tend to be secretive about their symptoms. They should keep their symptoms hidden. They are very reluctant to express their symptom and suffer from shame and embarrassment. And less than a third of OCD sufferers received appropriate pharmacotherapy, or even less receive evidence-based psychotherapy. If we see the diagnostic criteria of obsessive compulsive disorder, the presence of obsession and compulsions are both to be required. Obsessions could be defined either by recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbances as intrusive and unwanted, and that in most individuals causes marked anxiety or distress. The individuals attempt to ignore and suppress such thoughts, urges, or images, or neutralizes them with some other thoughts or actions, mostly performing a compulsion. So if we see the compulsion, then this repetitive behavior, it could be like repeated hand washing, ordering or checking, or mental acts like praying, counting, repeating words silently, and that the individual feels driven to perform in response to an obsession, or according to the rules that must be applied very rigidly. And the behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way. With that, they are designed to neutralize or prevent, or are very clearly expressive. So there are so many diagnostic challenges, and this is from the article by Dr. Janardhan Reddy, and it was published in Indian Journal of Psychiatry in 2017. And it compiles that it's sometimes it's very difficult to diagnose OCD because of the symptoms that can be like those of obsessive compulsive disorder. It could like anxiety disorder. It could be depression or schizophrenia or other form of mental disorder. And it is possible to have both the OCD and other mental illness concurrently. It also compiles that OCD is a complex and heterogeneous disorder, and in some presentation are under-recognized. For example, taboos thoughts that may be attributed to other causes or may not appear to be associated with overt compulsions. And even compulsions are not easily observable. And in patients with OCD, usually have some mental rituals. And patients are often reluctant to report to the OCD symptoms for a variety of reasons, including embarrassment, if the obsessions are of some sexual intent or blasphemy or something like that, or stigma, and that fear of the obsession might mean to the consequences of revealing it. So if we see the review of earlier research, that we can see that one German study in 2020, and it states that diagnosis of patients with OCD in outpatient clinic, and finding that the 70% of the patients remain undiagnosed and untreated. This was the situation of 2010. And much earlier, like in 2005 and 2013, and one qualitative study, and it noted that lack of knowledge and true understanding of the participants, mostly the assessors in OCD diagnosis on behalf of the professionals. And OCD presents in a variety of ways, giving way to a higher risk of misunderstanding of the disorder. And in one study, while some presentation of OCD such as symmetry and contamination obsession and compulsion were undiagnosed, were diagnosed accurately. And other presentations like aggression, obsession of pedophilia, homosexuality, fear of blurting out inappropriate things were less understood and more misdiagnosed by professionals. So due to the finding that most individuals with OCD first consult with their primary care physician, and one study conducted a survey to see that the rate of misdiagnosis of OCD weakness on the part of primary care physicians, and researchers have found that an average of 50%, 50.5% of the physicians used to misdiagnose OCD weakness, and 85% depending on the type of OCD weakness given. So here, the weakness with the topics of homosexuality, aggression, pedophilia, and fear of saying things resulted in the highest rate of misidentification or wrong diagnosis. So in an earlier study, the same OCD weakness were given to 360 mental health practitioners, and the survey format to determine the rate of at which another applicable profession was able to correctly diagnose the OCD. And it was seen that overall 38.9% professionals misdiagnosed the weakness, and with contamination weakness being the lowest misdiagnosed, that means the mostly diagnosed, the weakness of contamination, and at 15.8%, and the intrusive thought weakness were being the highest, that is 44.7% weakness of intrusive thoughts were misdiagnosed. So dangers of misdiagnosis and misdiagnosis, if we see that this inaccurate diagnosis can lead to a spectrum of varying issues, such as it could lead to depression, and it could lead to psychosis and suicidality. And for you, it may sometimes be maybe be confusing that in psychosis there might be lots of symptoms like OCD may be superimposed, and sometimes it becomes very difficult to differentiate what it is, what lies beneath, and we simply dump all those cases with a diagnosis of schizo-obsessive disorder. So in a systematic review and meta-analysis of suicidality in OCD sufferers, it was found that 10% of those with OCD have attempted suicide, and while 1/3 have current suicidal ideation, and on behalf that have suicidal ideation during their illness. And one study reported a patient who was misdiagnosed with psychotic disorder and thus placed on antipsychotic medication. And this patient ended up with worsening of symptoms, and including the psychotic delusion, suicidality, and hospitalization. And this was published in 2016. So dangers of misdiagnosis and misdiagnosis, if I say, in its most severe form, OCD sufferers have no insight into their own intrusive thoughts. This is a very important point to be noted, and it leading them to believe that the thoughts are real, true, and hold some meaning. And if a client lacks this insight, given the absent insight specifier of the OCD diagnosis, and their intrusive thoughts can appear as delusion and belief, just into a psychotic diagnosis. And in fact, the 41% of those OCD have psychotic-like experiences, adding to the confusion to the proper diagnosis. And as we see, the paradigm shift of understanding of OCD from anxiety spectrum to this OCD and related disorders, and it seems it is going more towards psychotic spectrums. And the accurate diagnosis and treatment can mean the lower mortality rates, as suicidality is very high. So a strong sense of self and less risk of self-destructive action and quality of life for such individuals is very much important, because OCD is, if you see the longitudinal history of the obsessive compulsive disorder, we can see it to be a very repetitive form of illness and a very chronic form of illness, and sometimes it remains as cushion state, and sometimes if the person is subjected to some stress, this obsessive compulsive disorder again relapses back in a very violent way. So this is all. This is all about my presentation. If anyone is having the queries, we can take at the last part of this presentation. And with this, I hand over.
These two speakers really gave us the total range, that the difficulties of these patients and the solutions that we offer to these patients. So I'll request if Dr. Rizaul Hamid can contribute some to this panel discussion.
And presentation of Dr. Parthapatim Kundu was very elaborative, very exhaustive, and it has covered all the aspects. And I suppose it has benefited the attendees of this webinar. If I give my personal comment on my topic, that was OCD. Before I should give a disclaimer, and that is the psychiatry is a subject. This is just like elephants being watched by blinds. Someone has seen the tail of the elephant, someone has seen the belly of the elephant, so it has been perceived like that. So I would just like to share a few of my personal experiences. So recently, one of the psychologists was doing some work at my hospital, and her study topic was OCD. And we were just exploring the data of our OCD patient, and astonishingly, we found that more than 90% of the patient had stress either in association or in maintenance or in relapse of OCD. The stress and OCD is very strongly associated. And personally, what I have seen is that as OCD is being taken away from the anxiety spectrum, though its few of the mechanisms, neurobiology may be a bit similar, near to anxiety spectrum, but its current shift to some other disorders, those are usually not having insights. So what I feel is that maybe it is going, maybe in the near future or distant future, maybe OCD will be taken under the umbrella of psychotic spectrum of illness. Personally, if I want to see is that I'm become very much tempted. I feel very confident if I add on antipsychotic medications concurrently with anti-obsessive medications. And I just share these 2 points to Honorable Moderator, Dr. Devashish Konar sir, and would like to know your opinion in this regard.
And I'll tell Dr. Rizaul that there'll always be a spectrum in many of these illnesses, even in OCD. There are many OCD patients who are not in the psychotic range, and they are very plain and simple and well managed OCDs who function very well. In fact, to encourage people, I always tell that obsession is a good quality. It can add to your advantage. Means if you are very particular and very meticulous in your work, you may become a good administrator, you may become a good scientist. Everything means it's to be meticulous is a good quality. It is only when it goes out of proportion and it brings in many other issues, then it becomes complicated and disabling. So if you are able to control these patients with treatment very well and give them the quality of life, so the problems may not be as difficult. But sometimes, as we all know, that whether it is bipolar or it is OCD, or it is bipolar or OCD, may be a difficult situation for treatment, but not so frustrated, I feel. Yeah, there could be possible good treatment which can give a quality of life to patients, and that is what we work for, and that is what we aim for. So we should always try to improve upon in our treatment and give best possible that we can offer.
Yes. Another thing, what I'm seeing, or what we usually face, the part of weight gain with mood stabilizer. Sir, what we can do about it?
From day one, you should tell the patient from day one that you should do exercise and to control diet, to also the patient and also family members. I know they fail sometimes, they are not able to manage that, but our duty is to tell the patient about these before weight gain starts. Once the patients gain weight, and then if you advise, it may not work. But from the very beginning, if you are instructing them that these medicines can give rise to weight gain, so you should do exercise and you should control your diet, especially low calorie diet, and which gives volume but not calories. So that kind of instructions I try to give from the very beginning. So that is why we say that psychoeducation should form the most important part of treatment.
I would like to comment on Dr. Parthapatim Kundu's one fact on lamotrigine actually. It's just an add-on. So regarding lamotrigine, actually, we should be aware of, we should be very cautious in young females. And it creates Stevens-Johnson syndrome. Several cases I came across, and these young females are very intolerant to this molecule. Otherwise, if you see from the perspective of weight gain or metabolic dearrangements or PCOD, as we can see in valproic acid and sodium valproate combination, or divalproate, we can see that PCOD is. So these are very less with lamotrigine, but it is a very strong propensity to cause Stevens-Johnson syndrome.
So with that, we end this seminar. We had a good deliberation. Thank you all. Thank you both. So I hand over the mic to organizers. And I
thank you so much, sir, as we are running short of time today. So thank you so much for joining this scientific session in your busy schedule, sir. Thank you, Debashish Konar sir, for nice moderation, as well as Dr. Parthapatim Kundu sir and Rezaul Hamid sir for your OCD and BBT part presentation. So with the permission of Debashish Konar sir, we are going to close our today's sessions.